So even though the new evidence or the new terminology, I should say, is just labeling stages of labor is one of two things. Either you're an early or you're an active. Okay, so it's kind of like absorb this middle, or transition into one big phase. Okay, so I say that to say, to just be familiar with both. So the way that we kind of termed labor is broken down into 3 stages. So early, middle, or what we call late or / transition has now become early and active labor. Because technically, not for nothing, once the mom gets to 4 centimeters dilated, she's in active labor. Okay, where the transition part happens is when we get to that 8, 9 centimeter, and they're starting to get the table ready and everything for the actual delivery. So those of you that have been in the labor room, have you actually seen, because I don't know, some of you are there longer than others, have you actually seen from beginning to end, so to speak? So have any of you seen where a mom is admitted, she's in labor, and then you're there to actually see the stages of labor, and then she gives birth, or you kind of like, I think some of you just kind of either walk in and she started, or you walk in and it's the end, but have any of you actually seen the whole or most of the process? Nobody? So all of you that have seen a birth, it's just, she's already in labor? Okay. So let me ask, when you guys have either seen report, have gotten report, or anything, do you understand the terminology when you're talking about how far along she is in terms of dilation and everything else, and fetal station? Professor Ando probably went through all that already, right? The fetal station. So in your head, if it's negative station, high or low? High, right. If it's 0, baby is even with that ichio spine. So baby's moving in the right direction, just not there yet, right? And then positive, baby's getting further down into the canal. Okay? So just so you understand that. So then when you break up the actual stages, the reason this becomes important is what we do as moms move forward in transition. Okay? So you have stage 1, where that's the actual dilation. The cervix goes from 0 to 10, because we need 3 things to happen for a vaginal delivery, right, to be successful. We need the cervix to fully dilate, we need it to completely thin out, so that's your effacement, going from, that's in percentages, so 0 to 100%. So think of it like as the cervix is dilating, it's stretching and thinning, okay? So that needs to happen as well. And then the third thing, the baby needs to be further down in the birth canal so mom can adequately push the baby out, all right? So that's kind of like stage 1. And then that's broken down into the 3 phases, or 2 phases now, okay? Stage 2 is pushing. So mom, once she gets fully dilated, fully thin, baby's down, right? She still has contractions, but the contractions shift, so to speak. So it's a different type of contraction, where it's more of the pressure, but she feels like this urge to actually push, okay? That's stage 2. Stage 3, which we tend to forget about, right? So those of you that have been in a delivery, everybody forgets about the placenta once the baby comes, right? But there is the placenta. So baby's delivered, then her uterus will continue to contract, which is what we needed to do. So what starts to happen as the uterus continues to contract, and that placenta will start to detach from the uterine wall, okay? So again, think of where the placenta is on that wall. All that is now open. All those vessels are open. You want that to continue to contract, so we cut off that blood supply. If the uterus is boggy, what is she going to do? Bleed and bleed and bleed and bleed. Okay. And remember, we talked about before, like the amount of volume that is going through that placenta. Okay. It is a tremendous amount, like 500 mLs go through between the placenta in the uterus. It's a huge blood volume, okay, transmission. And then the last phase, or what we kind of have labeled as almost stage 4, is that immediate postpartum period where mom is in recovery and we're assessing the baby and seeing how the baby is transitioning, all right? So again, first stage starts with regular uterine contractions, ends with cervical effacement and dilation, all right? True labor, uterine contractions are causing the cervix to dilate and thin out, which is what we needed to do. False labor is irregular uterine contractions, so they kind of come and go, they don't actually cause any real contraction, or I should say, they don't have a real contraction pattern, and they're not really causing any type of changes to the cervix, which is what we needed to do. That's what we kind of label as false, okay, or that contraction is. So that immediate postpartum recovery period, those of you that have been in L&D, what are they doing to the baby when the baby comes out? Bulb suctioning, okay, so baby, because remember, baby was breathing in what? Or has what in the lungs, I should say, okay, amniotic fluid, right? So once the head is delivered and the baby's pushed out, first thing they're doing is suctioning to get whatever in that immediate oral cavity in the nasal as well. Baby starts to take in its first breath. So all of those things are happening simultaneously, and they're doing what we call Apgar scores, which is a really quick way of assessing. They do it in 1 minute and 5 minutes. That's like what we do, right? And those of you, again, that have been in L&D, what do you notice that they're doing while they're looking at the baby? Everybody wants the baby to cry, right? Why? Because what does the crying let you know? Right, activity, baby starting to take in oxygen adequately. They're looking at the baby's coloring, they're looking at the baby's position, if it's floppy versus flex position, okay? And those of you that have been in labor and delivery, what else do you notice about the baby's coloring? Like it happens literally before your face. Baby goes from what to what? That bluish grayish color to pink. What starts to pinken up first? Face, head, and what else? Core, body. Why? Why does that pink up first? What's the body doing? Right, to where? All the major organs. We don't major organs live here, right? Not that they don't care about hands and feet, but they don't care about hands and feet, right? They want blood getting to the brain, which is why you'll see the face and everything pink up, okay? And like I said, when we get to baby and we talk about once baby's born, all those fetal adaptations that we talked about with fetal circulation literally reverse, okay? The baby's taking in oxygen. So that's why when you actually are standing there looking, the baby will actually change, and that is another way of letting you know baby is getting adequate oxygenation. And that's what we're really assessing with the kid, is how are you going from intrauterine, being inside of mom, temperature regulation is fine, to now baby basically has to do everything on its own, right? And transitioning from amniotic fluid being in the lungs to now the oxygen. Okay, so all of those things. So we're doing vital signs frequently, every 15 usually. Most facilities have the policy of doing vital signs every 15 minutes that first hour. And that usually includes heart rate, respiratory rate, and temperature. What else do you notice about temperature that they're doing? Where do they put the baby? A newborn. Okay. Some facilities might actually put baby to mommy, and that's fine. Mommy can act as a warmer, but that's like true skin to skin. Baby's naked, mom's, naked up top, and doing skin to skin, nothing between mom and baby. Covering up baby so baby isn't losing heat from its head or any other place. And so mom can act as almost like a warmer, okay? But most of the time, once baby's delivered, they will actually, dry the baby off. That's what I was trying to say too. They're drying the baby and switching out those blankets for warm blankets, okay? Again, because that's the source of baby losing temperature. So when they're first born, they're not stable yet, okay? So physiologically, all those systems are now having to do a lot of work to get that kid to normal temperature, heart rate, respiratory rate, all that stuff. Okay, so that's why we monitor very frequently in that first hour of life. Post that, the second most facilities have every 30 minutes, as long as baby's stable. Okay, so APGARs are done. They do the score at 1 to 5 minutes. They're doing vitals. They're checking baby, making sure that baby is warm and starting to vital signs are starting to regulate. If they need to do blood sugars, and again, that might vary, they might do a blood, it's not just because mommy has diabetes. I know you guys kind of automatically think that would be the initial. It could also be if there's any suspected infection, if baby is jittery when it's born, okay, which is something that you would actually see them shaking and just being more jittery. If they're small, if their weight is really small, if they're premature, they might do a blood sugar. If they're a big baby, okay, they can do a blood sugar. So there's a variety of reasons, not just the diabetes piece of it, why we would do blood sugar. So any of that can be done. The initial skin to skin, like I just described, with baby and mommy together is fine. There's more than enough evidence to support that helps with breastfeeding, that helps with bonding. So we want to see that initial skin to skin contact. If mommy is intending to breastfeed, we want the baby to actually, feed within that first hour and at least latch, okay? And then the pediatricians are there. If there's a reason for the neonatologist to be there or the NICU team, then those of you that have been in L&D might have seen them there as well. And again, that can vary, okay, as to either facility protocols or what's going on with mommy, or if baby has some type of abnormality, or if baby while mom was in labor was showing signs and symptoms of distress. Any of those reasons could be why the NICU team is there, okay? So again, what I was talking about, traditionally first aid was latent, active, and now it is early and active, okay, or latent phase. Latent is also considered early, okay? So if you hear the two terms, you basically mean the same thing, okay? And then active is what she actually is getting in, and what that really means, because women don't just, when they start labor, it's not that they have strong contractions. It builds up to that, okay? So it'll start off as cramping. Some women will complain of back pain, okay? So that's what we kind of labor as back labor. So it'll start literally in her lower back and radiate to the front of her belly, okay? So what you notice is in a lot of those pictures with the positioning is all of the positions mommy is doing something to get gravity to help her and get that baby off her back, okay? What have you guys seen in the labor room? Peanut ball, okay, which is, again, an alternative once mommy gets an epidural and can't do all those positions, right, as adequately. So again, it still allows for labor to progress, because you don't want her to not progress, and then she gets stuck, and then we end up with a section, okay? It's called the rest of labor. So we want her to continue to progress. So it is a thing of using that peanut ball to kind of flip her back and forth, okay? And get that baby down into pelvic position as well, all right? So physiological adaptations to labor. So some of these we've talked about in terms of those 5 Ps that that your book refers to. The other thing that you'll notice in terms of lab work, increased white blood cell count, which is, and I don't mean like super increased, but slightly increased. which is okay, because that just lets us know her immune system is working. All right, cardiac output, like we had talked about last week, cardiovascular changes. There's a huge increase in cardiovascular output because mom has a blood supply on board, so, that happens. Heart rate and respiratory rate, during labor, you expect it to go up, right? Because the body is going through a lot, so it's not abnormal to kind of see her at a baseline tachy, 110 to 120, during labor, especially during contractions. Same thing with respiratory rate. We're seeing an increase in heart rate. Respiratory rate is going to happen also. Temperature might slightly be elevated, but where we get concerned, a maternal fever is what? What would be our cutoff? Because that's in your textbook. And that would definitely be an NCLEX question and a professor quiz question. You want to know that. Maternal fever, 100.4 or greater, is considered a maternal fever. So we get concerned once mommy gets up to that point or higher, okay? So technically, if you're not pregnant, is 100.4 worrisome? That's more of a low risk, right? But if she's pregnant, in labor, or, even postpartum, 100.4 is kind of our threshold to start saying, ding, 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 what's going on? Is something brewing? What's the reason that mommy has a maternal temperature? Okay. Blood pressure increases during contractions, which completely makes sense, should return to baseline after contraction. So, again, while she's having these changes, and same thing with baby, which is what we'll talk about next week, chapter 18. With fetal monitoring and looking at, well, what exactly is going on with baby every time mommy has a contraction. Like, we care a lot about how baby is essentially responding to the labor. Those of you that have been in L&D, have you actually seen, I know all of you have walked on L&D and seen the strips, right? Have your nurses kind of gone through, or your instructors going through, like, what they mean and what you're looking at?
Yes.
Some yes, some no. Okay. But what essentially the reason that we do fetal monitoring is to monitor mom's contractions, to see, because obviously we don't want mom to have too many contractions, because then what can happen if she's having them too frequently, too fast. Right. Baby's not getting adequate oxygen and blood supply, because every time that uterus contracts at that peak, that it shuts it off, so to speak. Once the muscle relaxes, then the blood flow and the oxygen flow starts to return. But just like any other muscle, what's the uterus going to do if it's constantly doing this? Fatigue, absolutely, right? And if you have a fatigued uterus, what is mommy going to do? Postpartum. Bleed, right? Because now that muscle is too tired to even do what it's supposed to do now. So that's when you get the boggy uterus. That's when you start seeing mommy not contracting. It's boggy on assessment. She's bleeding and all those other things. And that's not what you want. So that's why we monitor what mom is doing in terms of her contraction pattern. And then the opposite. We don't want her like this, right? She'd be here forever. Like, she just won't be here all day, okay? So we need the contractions to come enough, often enough and frequently enough, so that it's causing the cervix to dilate, getting that baby down. So not too fast, not too slow. It's kind of like, what's his name? The Three Bears, right? Not too hot, not too cold, right? Yeah, so same thing with that. And then at the same time, we're looking at the baby. Well, is the baby chilling out? Or is the baby actually responding to every time mom has a contraction? Now we're seeing changes with that baby's heart rate, which is like ding, ding, ding. This kid is not tolerating contractions well. So even if mom's contractions are normal, let's say, she's having good contractions, they're nice and strong, mommy's fine, she's chilling in bed, and then baby is not having a good day, and you start seeing changes in heart rate, you start seeing changes in the pattern, okay? and deceleration, we'll talk about, in a couple of weeks. Over time, what do you think that's gonna happen, what's gonna happen to baby? Right, now you're gonna have a baby in distress, and possibly a dead kid if you don't do something. Okay, so then, at that particular time, you start seeing abnormal changes in fetal heart rate and fetal, heart rate patterns and everything on that strip. A decision needs to be made. Are we going to go back to the OR and deliver this mom, or what are we doing? Okay. Blood glucose changes as well. So kind of like what I talked about. So that's what some of the things I was just referring to is fetal adaptation. How well is the baby actually responding to the labor process itself? That's what we monitor on those strips. Okay. Fetal circulation, like we talked about. The other thing is fetal respiration. So one of the very fascinating things that the baby is able to do, it has reserve, it has a backup, okay, in terms of oxygen supply. The problem with that, though, is if it starts to run out, that's when you'll start to see a baby now in distress, now with all these abnormal changes. And now we need to figure out what we're doing in terms of either, like I said, either going back to the OR and doing a cesarean to get this kid out because now baby's in distress. Or are we going to do so? Are we going to stop with Pitocin if mom has Pitocin? Are we going to turn her on her left side? Are we going to give her oxygen? Are we going to give her fluids? Like, what interventions are we actually going to do to help alleviate some of these changes, if any? Okay, but that's where the clock starts to tick. So those of you, and those of you who have not been to L&D yet, okay, so it's still a good amount of you that haven't been. So when you go to L&D, a couple things, all the things I'm describing, look for. Okay, when you walk on the unit, you see everybody has the monitors right at the desk. Those monitors are everywhere. And that is so that someone is constantly looking at those strips all the time. So, for instance, the nurse that's taking care of that patient, if they go off the floor or whatever, they can't just walk off. They have to tell somebody, can you watch my strip? Because those strips can change at any given point in time. Baby could be completely fine all day long, just woo, and then for some reason or another, things start to change, okay? So constantly looking at that. So that's what that fetal respiration and the chemoreceptors are about. And the other piece to that is those chemoreceptors actually stimulate the respiratory rate once the baby's born, okay? So those contraction patterns that we're monitoring, the fetal heart rate pattern that we're looking at, the variability that we'll talk about as well, all kind of tell us what the kid is doing and how well the baby is actually tolerating the labor. It's hard work. Those of you that have been in nursery, have you started looking at the babies different now? Like, they are so tough. They look like they have had a hard day's work, right, when they're in nursery. And technically, they have, when you think about, like, everything that they've gone through, okay, during birth. So, when you break down the stages, mom is admitted, they do her history. That's why I was asking, have you actually seen them do the admission piece of it, okay? Because the admission piece is rather lengthy. If mom, and again, it might be a scheduled induction or a repeat C-section, so mom might not actually be in active labor. But either way, when they come on the unit, they're doing their admission, they're doing their history, they're doing the consents, they're starting the IVs and the fluids, because most of the time, once they come on the floor, they're usually NPL and they can only have ice chips. They also do vitals, baseline vitals, they do a baseline assessment as well. They put mommy on a monitor, see what the baby's heart rate is doing, and everything else. And then they also talk to the labor people, and like Professor Ando was just referring to, COVID has, Governor Murphy did an executive order last March, I want to say. It was earlier than that, because I remember we actually went 1 week with no labor support on the floor, and then he made an executive order. And so the executive order is still relevant now. So moms can have doulas, as a labor support person, in addition to their actual support person. So you know what happens, right? Everybody's mama and aunt and grandma, everybody is a doula. This is my doula, this is my doula, that's right? Am I right? You see that at
Well, now we require a printout of the certification.
Oh, you guys do?
We're like, prove it.
Wow.
Yeah.
Yeah, because you know by the state, they don't have to have any type of formal
For us, if it's additional, it's there.
certification.
Yeah.
Do you all know what a doula is? I don't know if we had talked about that before. So a doula is a certified, or they actually, and anyone can do it, you don't need to be a medical person, okay? You just basically take, the classes for it, and you get a certificate. That's what we do by certified. It's not even like an exam or anything, it's more of the, and it's really just to familiarize the things I'm going over with you all now in terms of, what labor is, how to support the person, the changes that the body goes through, once the baby's born, like those types of things. So anybody can get it, but at our facility, we actually have not required them, I wish, but, so once Governor Murphy did his executive order, then it was every, labor person had their partner or significant other with them, plus their doula if they had a doula. So right now, that's kind of like where we are. So the reason that becomes important, again, it was a really rough week, that 1 week, because when Governor Murphy shut it all down, and I mean shut it down, like the stores, like that time period, it was the hospitals responded with the visitation of nobody was allowed, at all. So on OB, it was a week of no support people. So moms were on iPads and, kind of the same thing as the ICU patients. If they were dying, they were on iPads with their loved ones during that time, because no one was allowed in. So it was the same thing for that week with deliveries. So now they are allowed to have someone with them. So active phase starts around 4, depending on that, and I think your book kind of supports that part, 4+ centimeters or whatever. And again, this is the point where the contractions are getting stronger, they're coming more frequently. She has a good contraction pattern, which is what we want to see, so they're coming regularly. Mom probably at this point is either, if she hasn't had an epidural, or some type of pain med to kind of help her. Some women, I'm not going to kid you, very few, I don't find a whole lot these days, but there are some women that just don't want anything. I don't want you to feel like everybody gets an epidural, because there are some women that don't want anything at all. Yes?
My patient had various pregnancies beforehand and no epidurals, and it was like, for this one, she was conflicted, and her husband was like, telling her, like, don't get it. But
The one that's not getting
it kept going for so long. And then she was like, all right, I'm gonna do it, and then anesthesiology went to C-section, and then that's when she had to wait to go to the baby.
So multips kind of go quicker, which is what it sounds like she was. But it doesn't mean, and I always tell patients, again, we don't give out, I tell them it's postpartum, we don't hand out trophies or awards or money for you not to get pain meds. If you need them, take them. Your body has to heal, and you can't heal if you're in pain. Like like they just don't go hand in hand. A lot of times in labor, women are worried about the babies, right? And rightfully so, because opioids cross the placenta, okay? But we monitor what the baby's doing, at the same time. And then in postpartum, they're worried about, well, I'm breastfeeding, I don't want to take too much. Because, and again, okay, we monitor the baby, she's not getting, you know, this exorbitant, like, dose that, you know, that we're giving her, but it is to help her, you know, tolerate the discomfort, yeah.
Is there a point during the labor, like time where it's too late to get that epidural or anything like that?
So, if she's already, good question, so if mommy, let's say, got all the way to 8 or 9 centimeters, but let's say she gets there, and she's like, I can't do it, right, because it's too much, it's too pain, I need something, so then they may offer, because she can get IV then, it doesn't have to be the epidural, you know, as an option, okay, also. Which some of them do, okay, like Nuvane's a popular one that we can give IV, it doesn't make them numb, obviously, but it helps to take the edge off a little bit, some of them can kind of fall asleep a little bit in between contractions, but once you kind of get to the end, and you're, you know, in that 8 or 9, and the baby's basically, you know, she's almost fully dilated, a lot of times, if you give it at that point, it can actually stop it or stall it, so it's more or less a pull. You can also give the epidural too early. So if you're in like the early phase, and I remember, me personally, and I know what, you know, what this stuff can do, they kept, I was really early, I was like, you know, maybe 2 centimeters, and they were like, what epidural? And I'm like, no, I'm gonna be sitting here all week, no, okay? I wanted my body to get into labor, like I just wanted, but believe me, once I got into labor, I was like, get in, deep I'm call her in, right? So yeah, so it is a time frame. You don't wanna give it too early or too late. The same thing once a mom has it, they try to start tapering it off, because, so that she has that, once she gets fully dilated, she has the urge to actually push, because it's a big urge, if, you know, for them to, they feel a lot of pressure, and it's like, I gotta get this kid out, you know, so that helps, versus if she's completely blocked, so to speak, and can't really feel, then the nurse looks on the monitor and says, okay, you about to have a contraction, get ready, and she's like, okay. It's not the as a woman saying, I don't care what y'all are doing, I'm getting this kid out, whether you like it or not, right? Okay. So that's pretty much what happens. So during active phase, the other thing we start telling her is breathing techniques. So we're not just telling her once she's pushing to breathe, but to help her breathe through the contractions. Okay. So breathing techniques, she will continue to be NPO, she's continuing to get fluid, she's continuing to be ice chips. So like you guys can actually, they'll love you if you get them ice chips, they really do. Because their mouth gets so dry, even though they're getting fluid, they're not technically dehydrated, but their mouth and their, you know, mucous membrane, they're just so, their mouth is just so dry. Okay. So ice chips, you know, those types of things, comfort measures, we're constantly assessing her pain throughout this process. All right, and any time that we give mommy anything, whether we're giving her IV pain meds, or we're giving her an epidural, or, you know, in some women come in, because they do have a birth plan, some of them come in with a birth plan saying, this is what I want, which is fine, I'm actually an advocate for it, because it at least gives them an opportunity to control what they can control within reason, right? And as long as it's safe and, you know, and everything, then if she wants the lights, then the lights. If she wants lavender, then, you know, spray lavender, like, whatever's gonna make her comfortable, then let's do it. You know, like I said, within reason. So that's, you know, those are all the things that you would actually ask on admission. So that's what we're monitoring for, and obviously we're constantly monitoring her labor progress, we're constantly monitoring what baby's doing, and that's all the way up until she's towards the end of that 8, 9, and she's getting ready for 10. And then women usually say either I feel a lot of pressure, I feel like I have to go to the bathroom, or something like that, that's usually like ding, 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 you know, and they don't check mom every hour. Those of you that have been in L&D, they don't do the sterile vaginal annual exams frequently, because why? What can you possibly introduce every time? Right, you increase the chances of introducing an unwarranted infection, and not for nothing, it's not comfortable. It's not at all. So every time you go in to check to see how far along she is, it's really based on her contraction pattern. It might be based on how long she's been in labor, and it's definitely, if she says, I feel pressure, I feel like I have to go to the bathroom, because the same muscles that she uses to have a bowel movement are the same muscles that she's going to use to push that kid through, and so they do feel a lot of pressure. So when they say those things, that's usually like, we probably need to check and see, how far along she is. The other thing, women come in with their membranes intact, right? So they haven't actually ruptured yet. So it's one of two things. She can rupture on her own, okay, which is called spontaneous rupture of membranes. Or the nurse, midwife, or the OB provider can go in with the amni hook and actually rupture her membranes artificially. So once the membranes rupture, she's moving. She's making progress, and the pain and the contractions are going to come more frequently, okay? So I always put this in here because I think students get into labor and delivery, and they're like, what do I do? Because it's not dependent, I should say it this way, it depends on your nurse. But you have more hands-on in the nursery and postpartum than you do labor and delivery. Labor and delivery, sometimes, depending on what's going on with mommy, is more of an observational experience. But it doesn't mean that you can't do certain things, because you can, okay? If the nurse, or ask, sometimes it's just asking. Those of you, how many, I already know most of you won't raise your hand. How many of you have actually done a, Foley? See, I know it was only gonna be like a handful. See, so the rest of you that have not, guess what Ellen does all day long? Foley. All day. I don't want y'all to go to nursing school and never put one in, okay? So this is the rotation, whether it's a scheduled C-section, mommy just came in as an admission, ask if you can put the Foley in. Or at minimum, ask if you can, just help with being, with assisting the nurse. Okay, but this is a great opportunity to get that skill in. Because when did you learn it in foundation, right? So this is why y'all laughing. Oh, y'all learning in foundation? Okay, so do I have to tell you one question until I go over it with you? Yeah. Just speak up. I wasn't around. Okay, so I will have asked them to go all the way back to just getting, this is a Foley, this is a two, like you see that? Okay. So I will ask them. Other thing is, a head to toe, ask. The nurses have to do it anyway. They do, they have to do their assessment. The only thing you guys can't do in nursing school is put NIVs. And that's okay, you learn that, once you are orientation. And most facilities won't let you do blood sugars just because, in order to do blood sugars, you have to be certified to do their point of care testing. And most places just don't have, the resources to in-service every nursing school that comes through their door. But everything else, like all the other skills that you all learn, you're basically able to do. So in this rotation, the big one is Foley. So I tell the clinical faculty to encourage you, especially on L&D postpartum. You haven't taken them out either, right? So postpartum takes them out, mostly, especially the C-sections, okay? So ask, just, if they have to put them in, they have to take them out. So while you're there, those are things that you all can help with as well, okay? And then the other thing is just being a support for the mom, for whoever's in the room. You can hold the leg, just, while mom's pushing, like there's things that you all can do and participate in. I don't want you to feel like you get on L&D and you can't do anything. Other thing, when moms come in, they look at, again, their contraction pattern, figure out, are they really in labor or is it false labor, obviously. And they do what we call a maternal fetal triage. I think there's like a nice graph of it. Triage index, the MFTI, which is a bunch of questions and assessments to kind of gauge and classify mom as emergent or not emergent. Basically, I'm simplifying it, but that's what the triage index is, okay? So when they come in, and you understand what triage is, right? So when and it's not just to OBs, when anybody comes in and needs to be triaged or assessed as to what the problem is, what are we doing, those types of things, they ask a history and questions, and then an assessment, and then a determination of how emergent is this, is this patient, or, how sick is this patient, or whatever, okay? Most of these we went through. Culture. In OB, and I always say birth and death are probably the most cultural things that you're gonna partake in as a nurse, okay? So, what does that mean? Does that mean that you need to put to memory everybody's culture or religion? No, but what it does mean is that you need to ask the questions to figure out what is it that they need or want during that time, okay? Some cultures, the maternal grandmother is like the primary important person. Some cultures is the husband, okay? Some cultures is hot or cold. That completely varies. Some people want their spiritual advisor, whoever that is. It could be a rabbi, it could be a priest, it could be a pastor, or whoever. Most of the facilities, especially the ones that you all are in, have pastoral care from all different, religions and everything. So any of those things that we can implement that are like culturally significant to the family or to the mom, then we absolutely can do that. We just need to ask the questions. Is there anything in particular that you need accommodations for that we should be aware of? Same thing as the patients know that it is a huge pet peeve of mine when patients that do not speak English, people come in and do sign language like that counts. Like they just talk with their hands or they talk louder. Get the translation phone. The hospitals legally have to provide information to patients in their primary language. So they spend thousands and really probably millions of dollars in technology and translation services so that can happen. So because if I was in another country and I couldn't speak the primary language and you're consenting me to do what, I need to understand what you're talking about. And again, that could also be a culture thing where they're not going to ask. A lot of cultures don't question healthcare people. They just trust you, okay? But again, being able to provide that education. So culturally, understanding what that means. We already talked about physical assessment. Some of this is a repeat. Back in exam, we talked about. Okay, labs. Some of the things that are done on admission, initially, we need a baseline complete blood count. And what is that also going to tell us? So that'll tell us all her basic stuff, her red blood cells, her white blood cells, her platelets. It'll also tell us her hemoglobin and hematocrit. The reason we need that as baseline information is because when she bleeds, we're going to see a change in those baseline numbers. So depending on how much blood loss she had during the labor, is also can determine what we're going to do in terms of management postpartum. So those numbers become very important because you need to get them before so that you can compare to the after, okay? They'll get a urine analysis. Any of her, especially if she was in prenatal care, and we had talked about this before, some of those labs that we get towards the end of labor, all the STDs we wanna know. We wanna know her GBS status, we wanna know her HIV status, so all of that information usually comes with her prenatal. Let's say we get somebody off the street and we don't know, we usually can run them, but things like GBS, I talked about this before. If we don't know mom's status for GBS, what do? They just treat them, thank you, regardless, because we don't have like a rapid GBS test, okay? If we don't know mom's HIV status, what do? We do a rapid HIV, okay? And that will tell us if she's positive, then we can implement the protocol, and obviously if she's negative, great, okay? So those are like the things that obviously we don't have when they come in, because that happens. We have moms that are from out of town, we have moms that haven't gotten into prenatal care yet, or we have some moms that never had prenatal care, and so when they come to our door, we have nothing on them. So then we get those critical important things, okay? Assessment of amniotic membranes and fluid when she comes in, so again, like I said, either she's laboring and she could be completely intact, so she has not ruptured, or she could have ruptured, either one. We need to, establish that. Once mommy ruptures, the time, we want to assess what time she ruptured. Let's say she ruptured at home, then it's just like, Mom, what time did your water break up out? Because, it's not going to be as accurate a lot of times. But that's important for us to know, so we know how long she's been ruptured for. And then what does it look like? These are called partum movements of the fetus. Did you go over this part in the first one? Okay.
We talked about
The mechanism of labor. Alright, so these are just terms that kind of describe how each part happens to actually deliver the baby. Okay, so they're called mechanisms of labor. So we have engagement, descent, flexion, internal rotation, extension, external rotation, and expulsion. So engagement, the fetal head passes through the pelvic inlet, and then the baby starts to move into the birth canal. The fetus, I've talked about this before, the position of the baby, chin to chest, okay, arms across so that the baby actually comes through that way. It helps facilitate so the baby, if the baby was like this, the baby would get stuck, okay? Shoulders would get stuck, arm be up here, so we want baby nice and tucked, right? And then there's an internal rotation where the head aligns with like mom's pelvis. Then extension, the head is delivered, so head comes out first. Those of you that have been in L&D, they suction baby, they get everything out the mouth and the nose. And then another push, and fetal shoulders align along with the anterior posterior diameter. That just is one big word to say that there's almost a straightening once the head is delivered. There's another turn of the baby. The shoulders comes out along with the body. So it's like head out, push, head out, they suction, mom pushes again, shoulders and body follow, okay? Stage 2, which again is that pushing part. So here's the thing, most of you probably have seen where baby, mom is fully dilated, now she's pushing. Some of them deliver in 15 minutes, some of them are literally pushing for 2 or for a couple of hours, okay? I know and I don't mean continuously pushing, but pushing like they're pushing, then they take a break, and they push, and they take a break, and they push, and they take a break. This is the phase where mom gets exhausted if that baby is not delivered, okay? They get tired of pushing and trying, and pushing and trying, all right? So even during this part, they're still evaluating baby, because now baby is further down, or should be further down into the birth canal. Why y'all taking pictures? We don't have it.
It's not on my phone.
Oh, it's like 3 after.
Yeah.
I think it slides, I think it move around. Yeah, I think it's there. We probably converted.
It's further down.
It's there.
Yeah, it's still not the same.
We talked about that before. Okay, episiotomy I kind of talked about, previously, so this is when while mom is pushing, if that baby comes out, is right there, one of two things, she might have a laceration, and we can state it as a first, second, third, or fourth degree lac, or they'll actually do an episiotomy. Most providers will do a neolateral, so they cut on the side as opposed to a midline, okay? Again, this varies, depending on how that baby is presenting. The whole point of it is so that that kid is able to actually come through, so they may need to cut one, okay? So in the stage 2, baby is delivered, yay, and then those of you that have been in L&D, they do the countdown, right? They're like, okay, ready? And then they start counting for mom to push, and the baby's out. So perineal lacerations are a degree of tears to the perineum, and they vary. 1 to 2 is not that bad in terms of what part of the perineum is affecting and the musculature part, versus 3 and 4. 4 is the baby has torn all the way through the rectal wall. So, back in half. That's why the episiotomy is done to kind of avoid that. So the 3rd degree even involves an injury through the muscles and the fascia of the perineum and part of the anal sphincter. So my patient, I had one patient I had years ago was really bad. She, and here's the illustrations of it. She had a 4th degree, and they repaired it, but not to be direct. That's how you got to see. I have another section about it's like that's all. So when they repaired it and she healed, she developed a fistula. What is a fistula? So she was pooping through her vagina. So she had to go back to surgery to repair it. Oh, yeah. Repair. So see this 3rd degree? This is a 3rd degree. You see this? And that's literally, so that's what the degrees basically are. So see this is the 1st degree here. It's a very minor tear, might be 1 or 2 stitches, but not much anything. Versus the 3rd, and here's 4th degree. Straight through to rectal wall. No, it's a very long repair, but they do it in the record. So, not to, I told you this was bring it all out. So this is the placenta. How many of you have seen the placenta? Did you see it? What did you think? Yeah, but I'm just talking about, they have to check it to make sure that it's intact. Why are they checking it to make sure it's intact? Right, so nothing is actually left wrong. Retained placenta is one of the reasons. What do you think the urine is not going to do? There's retained placenta. Correct? Or vitamins or whatever. If you like it, I love it, but yes, they do. They boil it at home and eat it. Was it diagnosed? So, yes, so if they're pushing, it's because they're concerned that mom is not, so they'll do maybe a little, well, you might have saw with a frontal massage, and it's almost like a pull at the same time without doing a manual extraction, and who saw a C-section? Okay, so those of you that saw a C-section, you didn't see that, you just saw them take it out, right? The placenta. Because that's more of a manual extraction, because especially if she's not laboring, the uterus does not cramp it and actually naturally detaching it from the wall, so they actually do more of a manual. That's why they check that's why that repair is so much longer, because you're not naturally doing those things, whereas in vaginal delivery you are. Okay, those mechanisms are in place. So this is actually what ends up happening. As the uterus contracts, starts to shrink down, this placenta will detach from the uterine wall, which is what it's supposed to do. And then they're pulling, which is what you're describing, they're pulling the cord, which should naturally elongate as it detaches. Okay? That's why they're checking to make sure that it's all intact and that there's nothing left. So once the placenta's out, and they're assessing the baby, they cut the cord, and, again, all those things that we had described earlier. So this is where now recovery starts, and this is stage 4. So that's that first hour of life, okay? We're assessing mom, we're assessing baby, and taking frequent vital signs, making sure baby is, transitioning well, making sure mom is continuing to cramp. So those of you that have been in labor and delivery, the other thing that they do, they usually hang Pitocin, right? And they just let it free flow so that it continues to do what it's supposed to do, post-delivery I'm talking about, okay? So that's what they're assessing. That's why you guys will see the nurses patting on mom's belly, all right, to make sure that her fundus is nice and firm and not foggy. All right, and they're checking her bleeding, they're checking her hydration status, they're checking her vitals, all of those things at the same time. If she had what we were just talking about, the perineum repair, depending on how bad that was, she may need to repair the laceration and also repair the episiotomy if she had both, okay? So this is why once they get to postpartum, if you have to assess that perineum, you gotta flip her over, make sure that there's no hemorrhoids, make sure that, that everything's gonna look red and swollen, I'm not gonna kid you, but you're assessing to see if there's a development of a possible hematoma, how her bleeding is, and making sure, because there are some times where the repair might not be adequate, where you'll still see, part of the perineum open, and that needs to be monitored as well, okay? So again, first 1 to 2 hours after birth, looking at mom and baby, and providing that bonding and skin-to-skin time, and mom and baby with the first latch, and feeding, okay? Post-anesthesia. So, if mom has had anesthetics on board, we also assess, the other thing that we need to assess is the epidural and the epidural site. Because the epidurals come out, they meet a very rare complication, can be where they develop a hematoma under the skin. So even once mom gets over the postpartum, you have to check that site and make sure that there's no edema or anything around it, okay? So looking at post-recovery, so making sure her level of consciousness is fine, her respirations are fine, her heart rate, all of that because she has had an anesthetic on board, which can, have adverse effects. So we do a post-anesthesia recovery check, so to speak, to make sure that mom can also feel her legs, that she's starting to get sensation back as well. This is the APGAR score that we talked about, so it looked at 1 to 5, respirations, reflex, pulse, skin color, and muscle tone. They basically, score, I think I have here it is. They basically give a score, 0, 1, or 2 points, and anything less than 7 requires an intervention. Something needs to be done, okay? That's not an adequate score. So ideally, 8, and 9, we never did a full 10, and I'll tell you why. Because, I know, when they made this up, right? The appearance and color, remember I talked about, so the skin is, will start to pinken in the face and the head and in the core, right? But the hands and feet are still bluish gray, and that's okay. And they usually pink up, within the first 24 hours. That's why you see how it says 2 points here for completely pink? You're never gonna get that at 1 to 5 minutes, basically, okay? So that's why the baby at most for appearance will get body pink, extremities blue, okay? And that's why they always get like a 9 and 9, they never get a 10, because that, they don't get the extra points. So 4th stage, things that you can do or assist with, and again, I'm just putting this in here more or less for your information as to what you are allowed to do, what you can do as a nursing student. Vital time, you can always do vital, there's never enough opportunities to do vital. When the baby, listen to the baby, even if you're not comfortable or good at counting the heart rate yet, because that really is a learned skill. But listen when they're first born, and then follow that baby to the nursery, and you will just see and hear, the progress of the heart rate and the respirations, and it like happens right before your face. It really does. Helping with, again, you don't let, when I say assist with breastfeeding, is not in the sense of you actually putting the baby onto mom's breast and helping with latches, the nurses do that. But maybe helping with the wrapping, helping to bring the baby over in the bassinet, something along those lines in terms of, assisting, or just staying with the mom while they, while they're in the room, okay? Did I take over this? So you did 16,
And then 16, and then one is 19.
Oh.
That's one of the anything after.
Okay.
But it's pretty much just reaction.
No, this is the next teacher. So here's the thing, right? So, which is what I was going to talk about today. We are already a week behind. So what you're not getting on this exam is fetal monitoring. You're not getting any of the strips. What's that, chapter 18? 18. You're not getting that because I technically should be doing 18 and 19 this week. I should be doing 18 and 19. So this is what I'll do. I will take this out and add this with 18. But you're gonna have to listen to a tape, because I have you can see, I can't get through it in 2 hours, I just can't. It's so much information. The other class has basically almost 3 hours. So I can see stuff with them, I can't get through it with you when I'm already a week behind. All right, so we won't put this on here, which is chapter 17, because this is about, epidural and anesthesia and stuff, so I won't include that. So 17 and 18 won't be on here. For the exam. Yeah.